start the introduction. Yeah.
Well, good afternoon, everyone here on Zoom. I'm Richard Cash. I'll be moderating today's talk and introducing our speaker, Kamradt-Scott, who is the Dr. Jiang Yanhong Visiting Professor of Global Health Security. I think I got that right, here at the school, and has just joined us very recently, I guess, the last 3 days. Adam specializes in global health and international relations and law, and explores how governments and multilateral organizations respond to adverse health events. He has worked with health professionals, politicians, and advisors, and has been a consultant to the Australian government on these issues. He's recently been a professor of global public health at the European University Institute in Florence, and he's presently chair of the board of directors of Global Health Security Network. He's the author of 3 books, numerous articles, and we're looking very much forward to hearing what you have to say. Negotiating the pandemic treaty.
Thank you very much, Richard, and hi guys. It's great to see you in person, and hello to everyone that's online. Let me just sort of first, I guess, start by extending my very deep thanks to Professor Michelle Williams, the Dean of Harvard TH Chancellor of Public Health, as well as Professor Marcia de Castro, the head of the Department of Public Population, who have made my time here possible. And it's really fantastic to be able to join what is undoubtedly one of the best public health schools in the world. So I'm really looking forward to the opportunity to be able to contribute to student learning, as well as the school's mission to make the world safer and healthier for everyone. And I'd also like to acknowledge the donor who made the visiting professorship position available. For those of you who aren't aware, Dr. Jiang Yanhong was the Chinese medical doctor who actually made public the full extent of the SARS cases in Beijing in 2003. So this was the first sort of SARS outbreak more than 20 years ago. And he wasn't very popular at the time with the government, obviously, because he contradicted the official government position. But nonetheless, his actions led to both changes to China's laws around sharing of information, as well as being hailed rightly as a national hero for a time. Unfortunately, he passed away very recently on the 11th of March at the age of 91 years. So I'd also like to acknowledge and extend my condolences to his family. But he does serve as a bit of an inspiration for this talk, and indeed the focus on open and transparent information sharing is one of the key issues which is currently being considered by governments under the auspices of this proposed pandemic treaty. And so with that, I'd like to get underway. What I will sort of start off with, though, is just a short note and disclaimer. I am an advisor to the Australian government on this matter. And so for those reasons, I need to make sure that everyone is clear that nothing that I say here can be or should be attributed or inferred or implied in any way to the Australian government. And I just make that acknowledgement on behalf of the government, for the government. And as any external consultant would appreciate, we can provide advice to governments, and what governments do with that is entirely within their remit. My job as an educator, an academic, is primarily just to help outline a series of facts and contextualize information so everyone can make informed decisions. I'd like to start, though, very quickly, I guess, with a bit of an overview of what we normally see with regards to international law and how it has developed. And I'd like to start here, particularly for the public health community, because international law is not something that we often come into contact with as public health professionals. It is somewhat unusual in that there are very few international instruments that actually deal with international law. There's a lot of standards and a lot of guidelines that exist out there, but in terms of hard law, there's actually very few instruments that exist. And so with that, it's helpful to sort of explain what we usually sort of expect to see. Now, in most cases, when it comes to international treaties, the first starting point is that we see that there is a problem which is identified. And in a very few number of instances, you actually then see a discussion as to how it is best to fix that problem. In a very rare set of circumstances, you will then see a consensus emerge around the idea that an international treaty or any sort of instrument would be an appropriate way forward. But again, I stress that it is quite rare that we actually see this. And it's usually only arrived at the idea that a treaty is the best approach once a number of other options have been considered. Where that consensus does emerge, though, usually what we sort of tend to see is that various drafting committees will be created, and those committees will meet at length, oftentimes over several years, to review various discussion papers, and eventually, progressively, they work towards what is described as a zero draft, which is the basis upon which negotiations then formally get to begin. But that process usually, like I say, is usually fairly protracted. And in fact, the negotiations themselves around the text of the instrument is also usually very protracted. It usually takes years for zero drafts to be negotiated, and it's not uncommon for decades to pass before we look at a final instrument or text being adopted. And to put that in context, we only really need to look at some recent international treaties that were adopted. And a good example there is the recent United Nations Convention on the Law of the Sea, or UNCLOS, instrument that was adopted with regards to protection of marine biodiversity in international waters. It actually took 15 years to negotiate that instrument. And that has only recently been adopted. If we were to look at the Framework Convention on Tobacco Control, which is the World Health Organization's only international treaty at this point adopted under Article 19, that process actually began or can be traced back to 1979, and the instrument was adopted in May of 2003. So you can sort of get the sense as to how long these processes usually take in order for treaties to be adopted. And in that process, then we see a two-step process whereby treaties are adopted, and then governments will be given time to pass domestic legislation to give effect to that instrument. And that second step is known as treaty ratification. After that, it's quite common then for a couple of years to pass before the treaty is then officially recognised as entering into force. And once it enters into force, those international legal obligations that are contained in the instrument then actually take effect. Until it enters into force, countries obviously usually tend to operate in principle or by the principles that are outlined, but it's not internationally binding until it has entered into force. In the context of the pandemic treaty, though, we've seen a somewhat different process really sort of play out from what we usually see. And in that instance, in December 2020, the President of the European Commission actually proposed that we should look to adopt a pandemic treaty. That call had been already flagged by the independent panel for pandemic preparedness and response, which was chaired by Ellen Johnson-Sirleaf and Helen Clark, two former leaders of their respective countries, in an interim report which had been issued in late of 2020. But the formal proposal for a treaty was then put forward by the independent panel in May of 2021 in its final report to the WHO, to the World Health Assembly. Various governments, particularly in Europe, then actually got behind this proposal and very much supported it. World leaders, for instance, more than 30 world leaders in March of 2021 actually published a letter whereby they indicated their strong support for the idea of a treaty. Some of the world leaders that were included in that letter of endorsement included France's Emmanuel Macron, Ukraine's Volodymyr Zelensky, as well as Indonesia's Joko Widodo. So we saw quite early on a number of world leaders really get behind this idea of a pandemic treaty instrument. I guess for me as a long-time observer of the World Health Organization, one of the more surprising developments has been the extent to which the Director General of the WHO, Dr. Ghebreyesus, has really come out very publicly in support of a treaty as well. Historically, when we see Directors General in the past, they have a tendency to be leave it to member states to make the decisions, and they often sort of will encourage or coerce from the background, but they don't often take a very public stance on something like this. But we've seen a very different set of actions from the current WHO Director General, and he has been one of the foremost voices calling for a pandemic treaty. Having said all of this, it wasn't really clear from the outset what the treaty would actually do and what the problem was that would be fixed. We all recognised that we could do better with how governments responded to the COVID-19 pandemic, but exactly how to do better was not really articulated in advance of this proposal. So in that context, we've actually seen sort of, the idea being for a treaty sort of operating in reverse from what we would normally expect to see. And following on from that, there was quite a lot of discussion and debate as to what was the best process by which we would proceed. So there were discussions about the venue as to which international organisation was the best place for the treaty negotiations to take place. And then there was also questions as to the nature of the instrument that would be adopted. And for those of you who are particularly interested in international legal matters, I realise probably not many, but there was a big discussion and debate that has played out between whether or not an instrument would be adopted under Article 19 of the WHO Constitution, or whether or not it would be adopted under Article 21. And I'm happy to get into the distinctions between this in questions and answers, should there be that interest. What we have seen then was a quite extensive sort of back and forth that ended up going over a couple of months as to what is the best way forward for this proposal to take shape. And in that regard, as opposed to the sort of standard process that we usually see, whereby form follows function, it's actually been quite the reverse in this particular instance. As I mentioned, we actually then had a little bit of a debate as to where the venue for these negotiations would be best conducted. The WHO was eventually identified as the most suitable location, although I will say on a personal note, I'm not quite sure that that was the best decision. Now, my reasons for that is that, as we will go on to discuss, there's quite a number of issues which are being proposed to be included in this instrument, several of which actually fall outside of the World Health Organization's constitutional authority and mandate. Now, the case was made, but ultimately not pursued, that a more suitable forum would be the United Nations in New York, whereby it would conceivably be possible to bring in other United Nations agencies, as well as the World Organization for Animal Health, which is not actually a UN agency, it's a private international organization. But ultimately the decision was taken, no doubt as a result of extensive lobbying, that the World Health Organization in Geneva should actually be host to these negotiations, and that's what has ultimately been decided. There's also been a brief period where discussions have also centred around the type of instrument that would be adopted. So one of the first proposals was that we should, rather than adopt a new international treaty, that we should consider revising and updating the existing international agreement, which is the International Health Regulations. And the IHR, as they are known, were originally adopted in 1951. They went through several revisions, the last of which was in May of 2005. I was part of those negotiations, so I can speak at length about the IHR, probably far more than any human being really would like to be subjected to. But the IHR serve as our current international framework, and upon which, it's the basis upon which we currently have agreements around international information sharing, around how government should respond to disease events. Related to that then was the proposal to pursue a new framework convention, and this the proposition that was put forward was that it should follow something along the lines of the Framework Convention on Tobacco Control, which is the World Health Organization's only international treaty adopted under Article 19 of the Constitution. The idea being here that we would see an overarching treaty be adopted, and then all of the details of that would then be progressively worked out. Another option which was discussed very briefly but fairly quickly rejected was the idea of pursuing multiple single treaties. And to put this into context, in international law, usually what we tend to see is that a treaty will be adopted to deal with one specific issue. And there is multiple examples that we can draw upon, such as the landmine prohibitions, such as outer space treaties dealing with very sort of single issue items. And so that instead of actually trying to aim for a overarching framework, that we would see, for instance, a treaty on international access to medicines or information sharing or genetic sequencing data, and that these instruments would be adopted individually. But as I say, that was dismissed fairly quickly by member states, and the fourth option that was considered briefly as well was that we would actually use Article 21 of the WHO Constitution to actually adopt a second set of regulations similar to the IHR that would serve to complement the existing regulations rather than aim for another formal sort of hard law treaty. Ultimately, governments decided on the first two options, but this in turn has also created quite a complex set of arrangements now, particularly because we are actually seeing those negotiations for both the international health regulations being revised and updated, as well as the the pandemic treaty now being discussed and negotiated concurrently. What we have seen as a result of that decision to pursue these two pathways simultaneously has been a very extensive and intensive set of meetings and international negotiations. And it's important to point out that several of these meetings have now actually been concluded already. And they are occurring in very quick succession. So if we look, for instance, at where we are up to now, the very next step, the international negotiating body recently had its 5th meeting, and member states are now preparing to meet in Geneva at the next World Health Assembly, where they will hear a progress report on what has occurred over the past 12 months with respect to adopting or pursuing this pandemic treaty.
Can I ask a clarification? Sure. The INB, is it also member states related or is it technical experts?
The international negotiating body is comprised exclusively of member states. So this is actually governments already sitting down to negotiate. So a zero draft text has been produced, and it's been upon that basis. They started out with the conceptual zero draft, or what was described as the conceptual zero draft, but they now do have a formal zero draft upon which they're now proceeding. But that is actually quite a recent development. I guess the 5th international negotiating body, or INB meeting, was one of the first instances where they actually sat down and looked at the INB at the zero draft text. And as a consequence of that, we're now seeing a whole series of proposals. Governments have sort of taken that zero draft away, and they're now coming back with a whole series of proposed amendments. I will flag one of the key changes that we've seen, or key differences around the pursuit of the pandemic treaty versus, say, the international health regulation revision process that was pursued back in 2004-05 has been that the current international negotiations have had several public consultations whereby representatives from non-government organisations and civil society groups have had the opportunity to present their own views and thoughts on the pandemic instrument. There have been sort of calls to make it even more transparent and that everyone should be able to see the multiple drafts that will be produced. But there has also been a counter proposal to that from governments saying that actually the textual negotiations should be kept confidential. That is what we usually tend to see with international treaties. We don't often see how the sausage is made. We usually see the final product. But nonetheless, there are calls for that. And what we sort of see, obviously, in the next couple of months is that there's a couple more meetings of the INB in June and July. Then they will take a short break and then they will resume again in November. And then there is a fairly quick series of meetings ahead of the next World Health Assembly next May, where it is anticipated and expected that this instrument would be ready for formal adoption by the World Health Assembly. Now, I need to stress, with all of those meetings and the dates that you've seen, these are just the meetings with regards to the pandemic treaty instrument. There is a separate set of negotiations that are underway with respect to the proposed revisions for the international health regulations. And it has not been uncommon for meetings to actually immediately proceed or follow after the pandemic treaty discussions. And what that means in practice, and the reason why I flag this, is that that has meant that the amount of work involved from governments to actually participate in these negotiations for both of these pathways, both the IHR and the pandemic treaty, have been very intense. And I think it is important to acknowledge the burden that that particularly places on many low and middle income countries that do not have permanent representatives in Geneva. They're having to send or having to make the decision as to whether or not they send delegates to attend all of these negotiations. And obviously some of the wealthier high income countries will have a team of professionals working on these issues respectively. Whereas oftentimes for low-income countries, if they have someone who is an international lawyer that has specialised in global health, then they're having to cover both sets of meetings basically as they're occurring, and that is creating a burden on member states. So it is quite an ambitious agenda that the World Health Organization has outlined. And as I have indicated earlier, there were multiple proposals coming from various different organisations and commentators as to what should be included in the new pandemic treaty. And it's not unreasonable to suggest that some commentators have even used the context of these negotiations to really try and advance the particular health issue or health-related concern. To help you appreciate how complex these negotiations are becoming, though, I think it's helpful to appreciate that virtually every topic listed here, with the exception of whistleblower protection, is featuring in the zero draft or some of the proposed amendments to the zero draft. So issues around One Health, wildlife trade, disease surveillance, travel and trade restrictions, all of these topics are currently either in active consideration or being proposed to be negotiated in the context of the pandemic treaty instrument. Now, this does raise a series of legal matters that warrant some reflection. And the first, I feel sometimes rather pessimistic to be the one to point this out, but it is important to acknowledge that the pandemic is not actually over. While those of us in high-income countries have benefited from access to vaccines, and we've been able to resume some semblance of pre-COVID existence, that is not the case everywhere. And it is also still conceivable, although hopefully it will not eventuate, that we would see a new version, a new variant emerge that may evade our current protections that we have from our existing vaccines. There could be further twists and turns ahead of us with regards to the pandemic that we haven't yet anticipated. And I flag this because from an international legal perspective, it's obviously not a desirable outcome to have an instrument being pushed quite aggressively to conclude, then to have elements of it which are either inadequate or insufficient, warranting us to then go back to the negotiating board so quickly again to then fix the problem. So we're hoping obviously that the pandemic will simply trail off and that this 2023 will be the year that we see the official end to the pandemic. But obviously it is a risk there that we have not yet concluded that process, the pandemic.
The definition, all of these things are just how you define it.
Yeah.
There's no absolute term, and then this treaty, I assume, is not for COVID-19. It's for whatever happens, whenever.
Yes,
So
in the future.
I'm not sure why that should have any bearing at all on what's going on.
I guess it depends on the extent to which there are further developments which we've yet to anticipate. So, you know, one of the challenges around the international health regulations was that it was really designed to prevent a repeat of the SARS outbreak in 2003. It wasn't really envisaged, or it was sort of anticipated that a pathogen would, if it was to emerge and start spreading internationally, that actions would be able to be taken much more readily to prevent a pandemic emerging. And that was what the IHR was really kind of envisaging to try and respond to. And this is the thing with the pandemic instrument. COVID, we've got the experience of COVID and we're predicating the instrument at the moment on that experience. That's what's informing a lot of the decision making. And yet there could be either further changes ahead or further developments, or the next pandemic could unfold in various different ways as well. So that's some of the challenges then with trying to conclude international provisions and obligations when we're not 100% past the current event. But again, I say hopefully it is a very small risk, and hopefully it is something that we don't need to be too concerned about. It is important to acknowledge, though, that while it is important that we strike while the iron is hot, while there is this political momentum for adopting a pandemic treaty, we haven't really yet taken the time to think through how we are genuinely going to enhance pandemic preparedness, prevention, response and resilience for the future. And instead, what we have seen is, in a number of instances, a number of proposals being put forward for what have been previously fairly poorly conceived solutions to health-related issues being now advanced as the proposal for responding to future pandemics. And I'm happy to sort of get into some of the weeds around what those types of proposals have been so far and why they may be inadequate. And I think it is important that, you know, we do have some time to reflect on what has occurred during COVID, and then also how to think through what sort of capacities we really need to ensure that we have for the future. The idea as well related to this of adopting a framework convention also has risks. And we need only look to the Framework Convention on Tobacco Control and the length of time that it took then to adopt additional protocols which then give effect to the instrument In some instances, one of the protocols has taken effectively 15 years from the adoption of the original parent treaty through to its entry into force. And so the idea that we think that this pandemic treaty will then have a material impact immediately on enhancing pandemic preparedness, I think needs a note of caution. I'm not suggesting that it's not going to help add to political weight for more health spending, but nonetheless there is a concern there with regards to how long it's going to take to work through some of the more contentious issues. Ultimately, one of the biggest risks, though, to the actual instrument being adopted is the fact that there's two concurrent processes underway. Now, I understand why some governments have felt the need to have their concerns reflected in both the IHR revision process as well as the pandemic instrument. There are understandably a number of governments out there that are very unhappy with how the COVID response unfolded, and in particular with their lack of access to medical countermeasures such as vaccines. And as a result of that, what we have seen is that governments have ignored the WHO recommendation that countries only propose minor amendments to the IHR and that they leave the major issues for the pandemic treaty. And what we've seen instead actually is that governments are trying to see both instruments capture the same types of issues and provisions. Now, from a practical perspective and a moral perspective, I understand their concerns and desires to do that. It does, however, start to undermine the political and legal benefit of pursuing a pandemic treaty, though, if you've got the same arguments being utilised for the IHR. So why would you then go through the process of trying to adopt a pandemic treaty if you've already got this covered in the existing international framework? And just to put it in context, the IHR is universally binding on all member states. Pandemic treaty, governments have the option of not signing and ratifying it. So it may not be universal. This is one of the key considerations between whether or not it's adopted under Article 19 or under Article 21 of the Constitution. So it does, the fact that these two processes are occurring concurrently does raise the prospect that actually neither would be successful. It is a risk that we need to try and counter and mitigate for. In terms of the more contentious issues that we have before us now, as you can appreciate, there's quite a number of proposed topic areas for the instrument and what it is going to cover, including, I'd like to point out some very important considerations around how we deal with future mis and disinformation, for instance, and what sort of measures governments need to put in place to ensure that we can counter misinformation, preventing things like vaccine uptake in the future. One of the early challenges, though, that we have to decide upon is what are the essential components for future pandemic preparedness? To put this another way, what are those components of the health system that you see as absolutely essential for pandemic preparedness and response in the future? Is it just disease surveillance? Is that one of the first starting points? What does that disease surveillance system have to look like? Is it simply sufficient that countries have a disease surveillance system in place? Or does it also need to cover multiple diseases and or species? There is a big emphasis at the moment on One Health and being able to be much more proactive in preventing zoonotic spillover events. But many countries around the world do not have any surveillance system for animals. And those countries that do tend to be countries that are exporting animals for trade-related purposes. And in actual fact, many governments also then don't want to publicise a disease event in animals because it can have trade and economic consequences. So even from a disease surveillance system, what are the essential elements here that we need to focus on? Because they then need to be reflected in the pandemic treaty somehow, so that governments know what their obligations are. What are the essential components then for the healthcare system for responding to a pandemic? Is laboratory capacity required? If it is, then what level of capacity? Does every country require a BSL-4 lab, for instance? If not, can that capacity be created at the regional level? Is that going to be sufficient? Things like logistics and transport systems are essential for ensuring that samples are able to be readily moved so that they can then be tested. Is that going to be part of a pandemic preparedness response capability that governments are expected to have in place, that there is a very robust logistical system in order to move samples around? Most public health professionals would probably say, no, that's beyond, a public health response, but in actual fact, it's quite critical to seeing an effective public health response to a disease event. What about genetic sequencing capabilities? This is emerging as quite an important issue for governments. We all have recognised the benefit of genetic sequencing data during COVID-19. Does every country require the capability to conduct that genetic sequencing? How is the data managed? Is it able to be shared openly, or should it be freely available? What are the implications for freely sharing genetic sequencing data? What we've seen in the past is that data that is shared freely is often then utilised by pharmaceutical manufacturers to develop medical countermeasures such as vaccines, but then they use that to sell at a profit. If you're saying then that you don't want that to happen, how do we design a system, and what would that system look like to make sure that that doesn't happen in the future? And this question between genetic sequencing data and access and benefit sharing is proving to be one of the most contentious issues in the current discussions and deliberations. As you can appreciate, a lot of low-income countries see this, this question around genetic sequencing data information being shared as a means to ensure better access and benefits. So, the system that is adopted here, and there is a big distinction between freely available and open access, which needs to be resolved as to what system is going to be utilised.
Just to clarify, that distinction is whether you need to pay for it, or?
No, not necessarily whether or not you need to pay for it, but for instance, at the moment, one of the big repositories for genetic sequencing data is GISAID, the Global Influenza Surveillance. So it was obviously set up for another disease, but nonetheless, they have a requirement that in order to access that genetic sequencing data, you need to agree to two conditions. Number one is that you acknowledge where the data originally was generated from. And number two, that you seek as much as possible to collaborate with the researchers that shared that data. Versus those who are advocating for a free system whereby it would simply be put into a database which anyone could access anywhere around the world. But then there may not be any obligations on those agents to then actually make sure that any benefits that derive from that are shared on an equitable basis. And so those are some of the sort of more issues. And what we're sort of seeing is a difference emerge between many lower middle income countries. They're saying we would prefer the open system, whereas a lot of high income countries are really advocating for a free system. That will have to be resolved, and then an agreement and structure set up to reflect what is ultimately then agreed upon. There's also questions emerging, obviously, around access and benefit sharing with regards to pandemic financing, for instance. So an investment in healthcare systems in countries. Is it fair and equitable that all countries would get access to international funds, or should they be required to demonstrate a level of domestic financial sustainability prior to that? A good question here, for instance, is, should countries be expected to be able to demonstrate that they've agreed by the Abuja Declaration, which advocated for 15% of health spending, or of annual spending being allocated to healthcare systems? And if they can't, does that then mean that they should not gain access to sort of international financing to further strengthen preparedness? From a public health perspective, you would arguably say no, that should not be a prohibition. You should want to try and encourage all countries to develop those capabilities, but at the same time, those funds are taxpayer funding from other countries. So how do you square that circle in terms of what is considered equitable and fair? And so, as you can sort of anticipate or at least appreciate, there is quite a number of very tricky issues. Now, these, in that context, we have now effectively 12 months by which these negotiations are to be concluded, and where it is expected that we would have a framework then that would be going before member states in May of 2024. So it is quite a tight time frame for those negotiations, which in itself does present a few risks. So with that, I will stop speaking there and have further discussion. Now, I'm advised that I need to keep staying here so that people online can see me, but I obviously would prefer to be sitting down. So please don't take this as a...
No. So let's, go down.
Thank you. Quite interesting. Two questions, maybe, if I may. One is that the narrative is very important and seems like it's focused mostly on the biomedical approach to pandemic control.
Yeah.
And we, at least in the initial phases, had a number of mostly low-American countries that did this the low-cost way, from using community health workers, Kerala, Thailand, Vietnam. Initially, they did very well without any technology, not by sheer brute force. Are those part of, or any of that approach is amenable to anything like a treaty, or we can't force countries to have sort of as developed of a primary healthcare system as Thailand or Vietnam or Kerala does, but maybe that relates to the 15%. Second question, if I may, is that initially you alluded to UN versus WHO. I'm curious to know, has that played out after a year of negotiation, that it would have been better to put it in much of what you discussed again seems to me in the mandate of WHO, but maybe we are missing the other parts.
Yes. So to deal with your second question first, I think it probably depends on who you talk to. So a number of governments and officials in WHO would say that the negotiations are going very well, and that they're engaging in appropriate levels of consultation and speaking with stakeholders from all the relevant organisations that have skin in the game in this instance. Having spoken to representatives from some of those organisations, they have a slightly different view. Some, for instance, have said we're actually only hearing about some of these discussions after decisions have already been made, and we're sort of being advised after the fact. So I think it really is incumbent on the World Health Organization to make sure that all of the other relevant international agencies, such as the World Organization for Animal Health, such as the United Nations Environment Programme, as well as the Food and Agriculture Organization, are feeling and believing that they are fully engaged in this process by WHO, so that we don't have, issues being agreed internationally in the World Health Assembly, only then to find actually it's not entirely fit for purpose, because then we are sort of further behind the ball again. And with respect to your first question around the emphasis on technical capacity, this is actually a really important consideration. So one of the concerns initially from low-income countries in particular was that the pandemic treaty would be used to create a whole series of new international obligations, which they would have very little capability of ever being able to meet. and so that the treaty then would become a further stick upon which they would be beaten, saying you're not meeting your international obligations. Now, I think it is important in that context that we do ensure that different experiences and capabilities are reflected in the instrument. So there is arguably a different set of expectations from a high-income country that has got a universal healthcare system versus a middle-income country which operates on a user-pay framework. But that's where it's really important to get into the detail as to, well, what are those elements of a healthcare system that are essential for future pandemic prevention, preparedness, response? And can you then ensure that all countries have an obligation and an equal expectation to meet that capability without it creating too much of an undue burden? The One Health element will be really interesting to see how that plays out. As I say, many countries around the world have no disease surveillance systems in place for animal health. And animals are usually categorized into 3 different cohorts. So we have companion animals, such as our dogs and cats and sometimes birds and even snakes, versus then food animals, versus then wildlife. And as I say, most countries that do have any animal health surveillance systems tend to focus on the food animals because they are then usually part of an export industry. And so they will have good systems in place for those because it has a real impact on the bottom line. But when it comes to even companion animals, there's no national system or a national reporting mechanism, perhaps. The World Organization for Animal Health does advocate for countries to adopt those sorts of standards, but again, it's quite ad hoc across the world.
Anyone else? Yes, Nick, please.
Yeah, so fascinating. In my day-to-day research, I encountered nothing like this, so this is great to hear. I'm wondering how much of the current discussions are being, I guess, shaped by the path dependence of the current pandemic in terms of, I think, say, concerns about responsibility and blame and extent of data sharing and timeliness, are clearly in the media still. Are negotiators still thinking about those, or is it sort of separating off and thinking about the future?
I think a lot of countries are still very much, the pain is still very real for a number of countries. And there is a fair amount of frustration and even in some quarters some anger with regards to how the COVID response unfolded. And so there's understandably then a fairly strong commitment to ensuring that we do not entrench what happened in COVID in a new instrument, and that it must be better. Now, one of the key mechanisms by which we're seeing this argument being advanced is in the zero draft there has been quite an extensive utilisation of this principle which I mentioned on the slides of common but differentiated responsibility. And a lot of low-income countries are using that principle to argue for a better and more equitable set of arrangements. And they're saying quite publicly, we're not willing to compromise on this. There needs to be better access, and we need to ensure more equity in how medical countermeasures are shared. On the reverse side, you've obviously got a lot of high-income countries which have got quite large historical investments in pharmaceutical industries and a lot of support to those industries that are wanting to protect the existing international property rights and so forth. And so how that is going to play out is going to be quite interesting to see, and where the compromise and common ground can be found will be really quite challenging, I think. But the short answer to your question is that no, COVID-19 is still very much featuring in a lot of people's thinking with regards to which we're trying to sort of come up with a system based on COVID-19 which has a better response in the future. And that's kind of the approach which is being taken at the moment. One of my concerns, for instance, has been around the current pandemic instrument. In the event that our next pandemic was actually instigated by an intentional biological event, there's actually very little evidence in the current pandemic instrument as to how that would be managed. Because if there is an intentional biological event, whether that was perpetrated by terrorists or a rogue government, whichever, you would end up automatically having a whole series of different actors being involved in a response. And from a national perspective, you would also have a lot more security agencies involved, including potentially defence. And the pandemic treaty at the moment, the current text, has no consideration for that. I mean, people sort of argue, oh, well, the public health response would unfold the same. Well, yes, to an extent, the public health response would be unchanged between a naturally occurring event versus an intentional event. But the actors involved in decision making around information sharing, the nature of the information which is shared, and those sorts of considerations would be impacted differently if it's an intentional event.
We have a, Bill Xiao has asked, please explain how the geopolitics play into the effort. For example, the US would not even establish a commission to deal with the COVID crisis.
Yes, and my own country of Australia, we have not, unlike some other countries, we've not done a national inquiry into our own response. The geopolitics is everywhere in these negotiations, I've got to say. We have already seen, for instance, that some governments have been less inclined to even counter or consider some of the proposals. So as you could all probably appreciate, there has been a lot of controversy around the origins of COVID-19. And so following on from that, one of the proposals for the new pandemic treaty has been that WHO should be granted greater access in order to be able to send investigative teams. Now, during the IHR negotiations, consensus could not be reached that governments would even be obligated to share samples because there were concerns that it would be used by some governments as a means to pursue other political objectives around things like weapons proliferation or these types of matters. And we've already seen that the People's Republic of China have obviously come out quite strongly about the origins. And so the extent to which we would see a consensus on some of the current proposals that WHO is able to send investigative teams and that countries are obligated to ensure that they have full access, we may see that the politics around that will be interesting to observe. And I will simply say, I mean, you know, it's easy to focus on China in that context, but I also think that some high-income countries like the United States or even my own country, Australia, in the event that we actually had an event kick off in Australia, I'm not sure, I'm genuinely not sure how the Australian government would respond to a request from the World Health Organization saying, we would like to send an investigative team to conduct an in-depth investigation, and you need to provide them with complete access to all of the information on cases and so forth. I would hope that the Australian government would actually would say absolutely 100%. No problems, welcome, we'll give you all the access. I don't know is the short answer.
I assure you this country will not close.
Yeah.
Yes, please.
Just
One, two.
So just picking up on these previous questions about origins, so not specifically about COVID, but of course linked with origins is a lot of information about the types of research that is in fact going on in laboratories around the world, which is largely secret. That's kind of one of the problems here. I was wondering, is that addressed within the pandemic treaty, more transparency on what research is actually happening in countries?
The short answer is no.
I mean, could it be kind of brought within that remit?
Not if you want the treaty to be.
Could I throw in an amendment?
Yeah, look, and I guess I don't know it would be interesting to even, and I'll say this openly, right? I don't know how much of that research is actually secret, as in it falls under national security considerations, versus we just don't have it talked about, right? So there's a lot of research around things like coronaviruses or other pathogens that goes on, but it never hits the news until we have an event, and then suddenly people are like, oh, it was actually an intentional thing, or the conspiracy theories about. So I guess it depends on the nature, but I would say that if anything falls explicitly under national security, then you will find that governments will be very quick to shut that down in the negotiations. Governments will not agree to anything conceivably that would be seen to compromise their national security, and in many instances their state sovereignty. And so this is even one of the big, I guess we were talking earlier about, or I was mentioning earlier, mis and disinformation. We've seen a big misinformation and disinformation campaign emerge even about this instrument, about these negotiations. And people are concerned that, the United States government is going to give all of its authority to the World Health Organization. That would just never happen. The United States government, would just simply not agree to give a lot of authority to the World Health Organization. There's discrete areas where international cooperation is recognised to be beneficial, and in that instance, but anything that involves those types of issues where it's actually genuinely secret, no, that would not think it's.
Yeah, we have one question.
So I would like to ask a video framework related to genetic sequence data or access and benefit sharing. And as you told us that Global South and Global North have different kind of intention. However, it's really important things to share this kind of data and create some kind of adequate medical countermeasure. And in order to do that, maybe COVID-19 technology access to CETA would be one of the framework in order to address the issue. But I'm not sure what kind of treaty or framework would be important to address the issue. So do you know if you know some kind of specific kind of framework or?
Well, some of the discussions at the moment rely on some previous instruments that have been adopted, such as the Nagoya Protocol. And there's a number of principles contained in the Nagoya Protocol that governments are saying need to apply here with regards to that. And that is, in particular, that countries are recognised as having sovereignty over certain genetic information. Now, that then is intimately tied to this notion of access and benefit sharing. Because if you do say and agree that governments do have sovereignty over genetic sequencing data which has been generated in that country, whether or not it comes from their citizens or animals or whichever, then there are flow-on consequences from that around, in the event that data is used to generate medical countermeasures, that those countries then should have either priority access or at the very minimum equitable access. So yes, there are frameworks out there and principles which are conceivably going to be utilised, but this is one of the questions now. And for those of you who are particularly interested in this, I'd draw your attention to, so the Zero Draft has been released. It can be found on the World Health Organization's website. There is also a proposal that has been put forward by the European Union, which can also be found on the web. It's available with a Google search, whereby they have put forward some ideas around the importance of genetic sequencing information sharing. But then they've also said quite quickly, we then need to build a platform and the framework around which that's all going to be shared. Because it does link to these questions then around what that data is used for, particularly in the event of vaccines or other medical benefits.
Well, I think we have to end at this point. We've reached the hour. I'm sure there are lots and lots of questions, but fortunately, Adam's gonna be here for some time. So your office is on the 11th floor,
It is.
and I hope the door is always open and so on. Because there are lots and lots and lots of issues that we hardly touched on, going all the way to the Indonesians withholding of genetic information, H5N1, and on and on and on. You can go on. We will, and we hope to have you back here. So thank you very much.